Luga. All right, everyone. Welcome to the webinar. You see a little change here. We're missing Ashley. She's out at another event pre-established. And of course, poor Rob Manske is not with us tonight. So it's Barb and I. And there's Dr. Voigt, who is popping
Awesome.
on as well. I want to introduce Luga Podesta, who is our special guest tonight, who will be talking about his article and his approach to PRP in ulnar collaterals. And then we have Daniel Kline, who will be joining us at the end. So without further ado, I want to thank all of our sponsors. I don't know if Mike has slides to start that, but I do.
Can you hear me, Phil?
Yeah, we hear you.
Just a participant now, I believe, coming in. I'm looking to see on the share options if I can get this up with there. If not, we'll just talk about it. On there, I'm trying to see where my options to share here are.
Well, I mean, we can just get started going. If
yeah, get started.
I mean, Mike, do you want to start? Did you have questions? Or do you want me to start?
Go ahead.
All right.
Welcome, Luga.
Thanks for having me.
It's usually not this messed up, and
that's all right. Every time I do something, doesn't work. So
yeah, and I will just say, before we start, we're one key thing. We're missing one of our guys tonight with Rob Manske. Normally helps lead it. Phil and he are the two co-leaders of that, and Rob had, I don't know many people that we get lots of followings on this webinar every month, but Rob had grown up on a farm ranch in Kansas. And much like the TV show Yellowstone, for those that are familiar with that, one of his sort of surrogates that helped raise him on the ranch was a cowboy named Spinner, and he would be the equivalent of Lloyd on Yellowstone. And he passed away, and Rob's there tonight giving his last respects to Spinner. So a tip of the hat to Rob. And I know it's not goodbye, but you'll see him on down the road, as the Cowboys would say. But Rob said to be sure to say hi to everybody tonight and give a nod to Spinner. So I said I'd pass that along.
Yep, thank you.
Awesome. Why don't we start with an introduction? My name is Phil Page. I am a professor at Franciscan University in Baton Rouge in the DPT program. And I think, what number are we, Barb? Do you know, 34 or something like that?
I think 38 is what I thought.
38.
Rob's the gatekeeper, though. He's the one that knows
Rob
everything.
Always knows. So shout out to all. If I have any students on, it's summer. It's the last few weeks of class. They have exams tomorrow. So I'll give you a pass. I'll turn it over to Barb.
Welcome, everybody. Thanks for coming again. I'm Barb Hoogenboom. I hail from Grand Rapids, Michigan. I work at Grand Valley State University, but only for 3 more weeks because I'm retiring in 3 weeks. But anyways, I'm the editor-in-chief of IJSPT, and we are thrilled to have Dr. Podesta and Dan with us here tonight to talk about PRP, one of the things that I know that we all probably do think a little bit about in our rehabilitation world. So thanks for coming, Dr. Podesta, and for Daniel.
Yeah, Dr. Podesta, why don't you go?
So where do I start? I actually prepared a couple of slides. I don't know if that's kosher or not with this,
Absolutely.
but talk about it, doesn't matter, because it helps understand where we are, where I was and where I am as far as treating soft tissue injuries in athletes or in everyday people with orthobiologics. Let me see if I can figure out how to share this. Let's see. No, that's not it.
No. While he's doing that, Mike, you can just jump in and introduce yourself.
Hey, I'm Mike Voigt. You guys see me regular with the team here. I'm in Nashville, Tennessee at Belmont University, and work very close with Barb and Phil with the journal doing things. So it's a great honor to do this. And again, as many of you know, that I see a lot of returning names popping in here, joining us this evening. It's kind of laid back, and I'm really excited about tonight with Dr. Podesta. We were very lucky this past week, Phil and I. We got to meet him at the
That's right.
meeting in Nashville. So we actually powwowed a little bit on the front side. when we did this. And I want to I know Barb's going to talk about this in a couple minutes, but we have Daniel Kline on with us tonight. And ATI is one of our title sponsors, and Manske with the foundation with research. And one of the things that tonight, I'm going to invite everybody that's coming on now to stick around at the end, because when we're done talking with our chat with Dr. Podesta, Daniel's going to start, it's going to be our very first one, but we're going to do a new series, a case in point series, coming up with clinicians at the end for just a short presentation. So this evening, Daniel graciously at the last minute, I know, was roped into this, as I've been told, with people he works with, to start us off with that. And I know, Barb, you're going to talk a little bit about this in the when it comes time towards the end a little bit more.
You want to just start with some questions, Doc?
Yeah, go ahead. Go ahead.
All right, I'll get started. I loved your paper, Doc. It was really good to see one of the early papers that was done on PRP with UCLs. And I'm not as in tune with PRP, I know, as Dr. Voigt is, but you know, I wanted to kind of know. I actually did a quick little search to look for other studies on PRP, UCLs, and pitchers, and I think like there's one more in the past 15 years.
There's a couple.
So
there's a couple.
There's a couple. There's no randomized controlled trials that I could find, unless you know of any. So you are the first to actually do this in a case series, which was great to show the improvements that you found. And I noticed in your paper you noted things like, at the time, this was 2012, and of course, you know, probably did the study, what, 2010, 2011?
Yeah, we published it in the AJSM in 2013.
13, okay.
But we started it around 2010.
Yeah, so in your paper, you noted things like there were no randomized controlled trials, that you wanted to see that. You noted there were problems with, you didn't know about concentrations and white blood cell counts and all that. Where are we today compared to where you were in 2010?
It's way different. Everything is dose related. That's why I wanted to show you this stuff if I could figure it out. How you doing, Ray?
Good to see you. Sorry I'm late.
All right.
You're not missing anything because I can't figure this stupid thing out.
Yeah, nice
Ray,
job.
why don't you introduce yourself, Raymond?
Hi, I'm Ray Mattfeld, a physical therapist, athletic trainer. Been colleague of Luga since 2016. Private practitioner for 24 years. Adjunct professor at Toro College. And been working with Luga since, as I said before, 2016 with all his clients.
Fantastic.
Ray neglected to say he was a PT, ATC for the Boston Red Sox for quite some time.
Oh, nice. Fantastic. Luga, if you find a tab that has the slides on it, that should open that up in that window.
The one I just zoomed out of.
Yeah.
Where the hell is this?
If you go down to your PowerPoint on the bottom, I bet it would open up on there, the bottom line, and click on the PowerPoint, see if that opens it.
There we go.
All right, there you go.
There we go.
Funny.
All right.
Just go to the
genius.
go to the slideshow. Perfect.
There you go.
Woo,
You're in.
we're in.
Oh, now what I do? Clicked out of it.
There
we go.
Just start talking.
Here we go. So anyway, so back then, I mean, when I was a team physician for the Dodgers at the time, and then wound up going on to the Angels, and where I did the majority of the study with my dear friend Lou Yocum, who unfortunately passed away prematurely. But you know, back when I was a fellow at Curlin Job, as you can imagine, we did a lot of UCLs and being trained. I'm kind of uniquely trained. I did a residency in physical medicine rehab. I was the first non-surgeon to ever do the Curlin Job Fellowship. And the first month I was there, I was on Frank Job's service, and we're doing a shoulder case, and I was the first assist. Job didn't, Frank never scoped anybody. We were just learning how to do that. And where I trained initially and did my first fellowship in New York, nobody was doing shoulder scope. So, you know, I'm standing there scrubbed, and one of my old partners hands me the scope, or one of my mentors there. He goes, "Okay, put this in the shoulder." And I started to shake and sweat. And I'm like, who you talking to me? I'm just like, and I'm like, I never even seen a shoulder scope, let alone, do that. So Frank put his hand on my shoulder and he's like, Luga, for you to be able to rehab it, you got to know how to do this stuff. So you're here and you're going to learn how to do all of this stuff. And that was
Wow.
the beginning of a unique training set for me, because even though I was familiar, I had done surgery and I had done trauma surgery before I went into PM&R. I was familiar in the OR, but this kind of stuff was new, and it was a whole new experience for me and helped me as I went along. But when I graduated, my fellowship in I guess it was 1990. Um, I was a team physician for the Dodgers. I was doing other teams, high schools, colleges. And I mean, really the only thing I had was, I mean, being able to, put them in a rehab program or direct that. I could do EMGs, I could do cortisone shots. I mean, that's about it. I could diagnose, and then about 2005, a Stanford professor, Alan Mishra, published a paper in the journal on treating tennis elbow with PRP.
Mhm.
And a bell went off in my head, or a light went off in my head. Hey, man, this is a way that maybe we can start looking at treating UCL injuries or ligament injuries or soft tissue injuries for that matter with this modality. So we started looking at it. And when I set up this study, there really wasn't a lot of literature out there. Everything was all over the place. One injection. There was really no consensus on what to use, how to use it, what color it should be, what
Mhm.
cells should be in there, because we didn't really have the technology or the knowledge. And I say this all the time. I put this all in red because the only thing I knew back then, blood was red, and I had no idea anything else about it. And if someone told me I would be doing, cellular work with blood and bone marrow, I tell them you're out of your mind. I mean, because there was no way I was doing this. I wanted to be a team physician, not this. Anyway, one thing led to another. So we were looking at, you know, UCLs in our throwers, especially on the professional level, but more so because of my work with Major League Baseball, I started to see more and more younger and younger kids with these problems, and there was no really great option for them. Either they stopped throwing or stopped playing or waited till they were skeletally mature, or
Mhm.
some miracle came about, because back then we were only doing this on professional athletes. I mean, most college athletes, collegiate guys weren't even getting this done, until we started to try to figure this out from a non-surgical standpoint. So when I set this study up, it was basically, the literature was all over the place, so it had to be simple. I mean, it was going to be one type of PRP, one injection, one person doing it. The study was basically pass fail. Either you were able to continue to throw at the same level when I was done with this, at the time frame was a year and a half, or you weren't, and it was a failure. So we enrolled 34, 37 originally, patients. We split them up. There was 28 males, 6 females, 27 baseball players, 3 softball players, 2 tennis, 2 volleyball players. And the ages ran from my professional athletes to my high school kids. And the majority of them were pitchers, but we had, softball players that were infielder. I think one softball player was a pitcher. And then we had some of our younger pitchers that also played in the field. So we started this study. We're gonna use a single bioformulation of leukocyte-rich PRP. The reason I picked that, other than being pretty much a kind of educated guess, was because that, in my mind, would give me the largest number of platelets, which I thought, or growth factors, that I thought was the biologic structure that needed to be basically injected in to get this to heal. Each player went through two months of conservative care. In the literature back then, Reddick's study really didn't show much, or really a great results with doing a non-surgical program. So they failed this, and then we put them in the study. Each participant received a single leukocyte-rich intraligamentous injection. And you can see this is one of the first ones on the side. You can see the tear at the tip of the needle, and then the ligament behind it.
Mhm.
And this actually was a high-grade partial tear. You know, we used one system that I thought was going to be able to give us the amount of cells that we needed, although we didn't know what that number was.
Mhm.
This was able to give us this system. We drew 60 mLs of blood. It produced 5 mLs of PRP. We stuck that all in, which was probably way too much. The product and the manufacturer said it was 7 times baseline. I don't know how true that is anymore, because most of them are not. You know, so we did the injection. At first, we were pretty aggressive with therapy. I had some of the best guys in the world, I thought, you know, doing the rehab on these, and we were just way too aggressive. And a couple of our pilot studies failed. And I'll go over that, as well as Ray can probably attest to that as well. So we kind of I came up with a rehab program. I hate protocol. I always use rehab progression because it's goal-based. Over a 12 to 14 week period, we looked at subjective scores like the dash score, the curl and job thrower score, dash throwers module for subjective data, but that wasn't enough for me. I knew if I was going to try to publish and make this meaningful and not have any of my baseball colleagues laugh at me, I had to have some objective data. So we actually validated a way to do dynamic ultrasound, which was going to be able to give me objective findings, whether the ligament was torn, whether the joint stabilized over time. And I'll show you an example of that in a minute. So we did, we did a pre-injection dynamic ultrasound of both arms at rest and with a 10-pound kettlebell, basically providing a valgus load. We came up with this because the equipment that was on the market, a Telos device, if you're familiar, it's a big clumsy device that we use to measure stability and laxity. But it was hard to use it with a thrower, especially if you try to bring it into the training room. And these devices were about, I don't know, $10,000, something like that. So we wound up doing a side study validating the kettlebell versus the Telos and 2 of the college baseball teams that I took care of. And the only difference was the price. One was $10 and the other one was way more. You know, so we published that, but that's what we used. And we did that monthly intervals from prior to the treatment to a year and a half after. And the caveat also with this is that they had to complete the player had to complete one complete season before we'd do their final test. And success was graded basically only if they returned to throw at the same level or better. And return to play was about 12 weeks in a range from 12 to 15 weeks. You know, so back then we didn't really know a lot, but what we know now is we were probably delivering back then 3 to 5 billion platelets per ml, or 9 to 12 billion total dosage of platelets. And this yellow image at the bottom is one of the PRP samples that we can do, and that wiggly stuff on the bottom that looks like brains, that's the buffy coat, and that's where a good portion of the platelets are, but the majority of the platelets sit in that little red layer right below that white cloudy stuff. That's where the most of it is. And that's what we've learned over the last 5 years, where to get the biggest and most active platelets. So we looked at our subjective scores. They were all significantly positive. And what we learned, particularly pertaining to how we're going to rehab these and not let these fail, was when they actually healed. So at 6 weeks, we actually saw that there was a tightening of the joint with valgus load compared to the opposite side and compared to prior to what we had done prior to the treatment. As you can see here in the red, there's a big gap there. That's about 0.35 centimeters or 35 millimeters, where on the other side, significant difference, you know, of 19 millimeters compared to the original one. You know, when I saw that and I saw that the ligament had healed where it was originally torn, then we were able to safely introduce valgus loads. And I thought that was a big milestone for us, because now I was able to safely stress that ligament. And this pertains to every ligament I treat, not just the UCL. You know, and then once we were confident with our players' strengthening of the shoulder and around the kinetic chain and around the scapulothoracic joint and then the lower arm, then we could start an interval throwing program and proceed from there. And then we had total 30 out of 34 return to the same level of play, 88% or higher in 12 to 15 weeks. This 88% is actually artificially lowered because I had a player at the 12 or the 3 month mark. He was able to throw, but he developed a slap lesion in his shoulder and he couldn't throw, so he was a failure in the study. Out of Buddy Savoy's group out of Tulane, a couple of years later, published a study actually using my study as a guide. Instead of doing one injection, they did two, same bioformulation, had the over 90% return to play rate that we would have shown, but they did it a little differently. But the results were pretty much the same with the same bioformulation. So I used to take a lot of grief at meetings because the best line I would always get is, Luga, what happens at 6 weeks if this doesn't work? And I would always say to the surgeon that asked me that, well, what happens in 18 months if a player can't throw? And then I shut them down right away because, I mean, I knew at 6 weeks I could dynamically stress them. If I saw that ligament tighten down, very few of those, if ever, failed. And even if it did she'll still show laxity, we can go two ways. We could either do another injection and boost it, or we can send him for a Tommy John. So you don't really lose a lot of time. Anyway, so I was always taking grief about this. So I was asked by my academy, American Academy of PM&R, they were doing a symposium on throwing athletes, and they asked me to give a lecture on, is PRP treatment for UCL injury or just biding time for a reconstruction? So that kind of aggravated me a little bit. So I went back and my original 30 guys that went through the system, or 34 guys that went through the system, we didn't lose anybody to follow up. I was able to see them all. That was from a period of 2010 to 2020. And I asked them a series of questions plus examined them. Were they able to continue to play competitively? For how long and at what level of play? The second question was, were there any recurrences of medial elbow pain or UCL injury? And the third one was, when did you stop playing or retire from baseball, and for what reason? And the findings were, this is the paper that I'm still in the process of writing now. 94%, 29 out of the 30 continued to play at a minimum of 4 years at the same level. 34.5% of those, 10 out of 10 of the 29 continue to play for 8 levels, most of those at a higher level. One player sustained a shoulder injury, was knocked out of that group. There was no new recurrences of UCL tears or recurrence of pain in the medial elbow. 100% continued to play recreationally, and none stopped playing or retired from baseball because of the UCL injury. So all this is really, what we know now is due to how we approach the dosage. You'll hear people say not all PRP is the same, and that's true, because I don't know why the hell that line is there, but that wasn't there before. Anyway, but
that's the injection.
Yeah, but but we didn't know this, but the more we learned, the more we were able to extrapolate to other tissue. And there's different nuances treating other tissues that we won't get into today, but for ligaments, we know that there's a certain number, and there's a dosage, just like a drug. It's a biologic drug. It's important. So when we look at this stuff, we're looking at bioformulation, the amount of blood we collect, the PRP volume that we concentrate, the capture rates of the devices we use, because they all give you something different. The overall dosage, which is very important, the size of the platelets, so that's what the MPV is. This is something we stumbled on just recently, just submitted the paper for publication in the Orthopedic Journal of Sports Medicine last week. The concentrations over baseline, we're concentrating anywhere from 10 to 20 times baseline, where back when I was in California, we were lucky to hit 5 to 7 times baseline. Now for bigger tears, athletes with more demand on their elbows, we're actually optimizing this with a concentration of, quote, stem cells or bone marrow concentrate to boost that production. We know there's a synergistic effect between the two when we add them together. And we call that bioformulation optimization. Then we can activate this. We can do different things to keep them, to let these growth factors spill out their potentials right away, or extend that over time. And then again, I'd be remiss, especially in this group, everybody thinks this is like crazy glue. You squirt it in and you don't do any rehab, you don't do anything. I mean, the rehab is a huge part of this. If you don't do this correctly, I can guarantee you this, none of this stuff will work. And I see that all the time. This is kind of the things we look at from a cellular parameter, and I do this on every patient. Try to figure out where we got to go with these pathologies around that red disc, and these are the cells that we concentrate. We actually wrote a study. All soft tissue has to grow, needs blood supply, and we did a study on angiogenesis, looking at who responded to certain PRP treatments and who didn't. And what we found was that those that responded to a bioformulation of leukocyte-rich or neutrophil-rich PRP, as opposed to those that weren't in that bioformulation. And the dosages with the neutrophil-rich or leukocyte-rich PRP, the platelet doses were much higher than those that weren't made in that bioformulation. And this is a plot that we made with looking at soft tissues, ligaments, and tendons across the board. The stuff to the left in the pink circle were all these subpar or subdosed bioformulations that were treating patients, and these patients pretty much did not do very well. What I found out was mine was probably the highest out of the things that were published. That's the yellow line with my UCL study that was out in 2013. So I mean, for once in my life, other than probably marrying my wife, I have to say that because she's listening in another room. I made the right guess at one time. And then the other studies, there's a couple of studies my study was always compared to, one by Josh Dines and my old partner Elatraj and a bunch of guys. They used something called ACP, which is from Arthrex, and ACP, the concentration is not more than two times baseline with the cellular count, which was not much, 412, thousand cells, as opposed to what the hell we're doing. Back then it was probably 780,000, and now we're doing way the hell over a billion. The last one I was talking about that came out of Buddy Savoy's group in Tulane, that's the study that basically repeated ours. And those were the numbers that they got, which was pretty much equal to what we had. And then basically it comes down to the rehab part, and we could talk about this next, but basically we learned, unfortunately, the hard way, and doing this now for 25 years, we've learned how long it takes different tissues to heal. We know we have to follow the natural healing cascade, which is what this multicolored circular oval diagram shows us over time. Patients have to hurt after this. I get worried if it doesn't hurt, because the way our body heals, we go through an inflammatory stage, and then we go through a proliferation of cell stage, and then a remodeling stage, and that can take, in the best of experiences, over a year. The inflammatory stage is only a couple of hours to maybe 2 days. If that doesn't occur, none of the rest of it happens, or it gets damaged. So we've tried to set up our rehab to follow these guidelines, as far as this goes. Typically, I'll hold them for a couple of weeks. I'll have them do range of motion, particularly with the UCLs. Initially, I'd let them move right away because they weren't big lesions. Now I don't trust any of them. I lock them down in a brace, and I'll open them up 10 degrees. I'll keep them in a neutral position, in a brace that I can open up the hinges. I'll keep them neutral for 2 weeks, and I'll open up 10 degrees total range of motion. The next week, another 10 the next week. Then I open them completely, keep them there until about 4.5, 5 weeks. And then usually I bring them in, if I can see them, back where I am, in either my LA office or my Naples office. Then I'll, if they have a normal moving valgus stress test or milking maneuver, they have no signs of pain or anything like that, their motion's pretty good, then I'll ultrasound them. And if I see what I need to see on ultrasound, then I clear them for valgus load. If I don't, then we got to make a decision what to do. And that's how we proceed it. But everything is about, when to load them, when not to load them, and how to load them. And I'm sure we'll talk about that in a minute. This is the kind of thing we look at, and this is a chart we were able to put in our chapter that you guys all have, as far as as what particular tissue loads, how do we load those tissues, and when do we load them, and how do we ramp that up over time? And I'll let you guys talk about this because you know a hell of a lot more about this than I do. And from a success rate, when I teach this to other physicians and therapists and everybody else, really blood supply is the key. You got to get angiogenesis to reoccur. And you can only do that a couple of ways with certain bioformulations or using a combination of different bioformulations. The deliverable platelets, we're looking at 9 to 12 billion delivered in one small aliquot of blood. Some people believe in 2 injections, 3 injections. Every time you stick a needle, inject the fluid into it, you damage that tissue and you start from the beginning again. So we try to load it, the most cells in the lowest amount of volume. And we try to use equipment that's going to give us higher than an 85% capture rate. At first, we used to only treat the lesion. Now we treat the whole ligament because what we were finding is that I was seeing patients that smell like a UCL. He complained of a UCL, but the MRI images didn't show that until we did a dynamic ultrasound. We can see a laxity between the 2 sides. And anything more than 1 to 2 millimeters is considered lax. Job used to tell us when we went in, if you pick the ligament up with a forceps, you can pick it up off the bone, it was unstable. And he was right. And that's what we go by now. We'll protect those, for 3 to 6 weeks. I protect them all now, especially if I don't trust them, and I don't trust any of them with this injury. Dynamic ultrasound is critical for an evaluation. I mean, I see this all the time, and I've argued with pitching coaches, GMs, college coaches, parents, you name it. Everybody's like, oh, do the PRP, and I want them back in 6 weeks to throw. That doesn't work. They're not ready to throw, and we've proven that, and Buddy Savoy's group has proven that. And then finally, from a post-treatment rehab standpoint, we've designed it to follow and match the healing cascade, try to match what loads and stresses we put across in congruence with how they actually will naturally heal. Dynamic imaging, when you treat ligaments, is of paramount importance because you can't really go any further without doing that. You need to know, where you are in the healing process. It helps us guide appropriate exercise progressions and load applications, eventually getting them back to their sport. But that's it for the slides.
I got a couple questions for you, and we
go ahead. Sorry.
Tonight, Luga, we kind of did this a little backwards, and we wanted to get to the article because that's what we really asked you to talk about, being we're in baseball season, and I suppose for everybody that's on the Zoom tonight, we want to pull back, and Ray's here to help us, talk about rehab and biologics in general, but it looks like in your paper, and again, good job with that. In that, I think if you go back to that classic paper with Reddick in 2001, I mean, they had a return to play from a non-operative, as you point out in your paper, at 42%, and you guys got up to 88%. I mean, more than doubled what they had. But did it actually show when you had the slide up a little bit ago? But when you did your dynamic ultrasound measures, it almost showed that over time there was a decrease. I think it went from 28.7 millimeters down to 20. So did that medial joint or the ligament, do you think, as you did, because you had your hands on, but did it actually tighten up on that side?
Oh yeah, that's what we're looking at for sure.
Right.
And that's
what would be your biological mechanism? What do you think really, what's really going on?
1 second. Why don't you just stop sharing your screen? Hit that bottom thing where it says stop share screen. We'll get more faces. We got the big zoom in our face.
Uh-oh, okay.
Me or you guys?
You need to stop sharing.
Oh.
Down the green button, I guess.
Maybe I can do it.
I had stop, I think.
Let's see if I can.
No, every time I hit it, it comes back up.
It's okay. It's usually if we can get that big thing, there's a big zoom thing in the middle of the screen.
Oh, a zoom picture?
Yeah, it's just a big white screen. Yep.
How about now? No?
Still there.
Oh, wait a minute. Let's try that.
There it is. You got it. Perfect.
It was the big red button that I missed.
The other thing I was going to say too is to the audience, we've only got 2 questions in there. So if you have questions for either Raymond or Dr. Podesta, please type those in. We're going to try to get to those in a minute. A couple are up now, but go ahead, Mike, you keep going.
Well, I
Mike, to
said,
answer
you
your
know, what do you
question,
propose? What's the what do you think's going on? I mean, it's just
so we can
accelerated
actually
healing.
get soft tissue to heal.
Yeah.
We've shown it in tendons, we've shown it in muscles, and we've shown it in ligaments.
And I guess, and again, I'm asking questions sort of more global for the audience on this. And you said it quite nicely. And I think Phil may have a question around this as well. But you said multiple times, not all PRP is the same, and
Right.
not everybody's going. And I think that's what, obviously, in my opinion, that's one of the problems in the United States, and probably one of the problems with the literature going back in time, because people didn't used to report concentrations and doing things with that. But I guess I'd just throw it as a global. Do you think in a soft tissue injury, I suppose, we're talking ligament today, but with your paper, but we could do muscle tendon. Do you think PRP is a viable alternative for everybody, or are there certain indications you look for?
For the majority of people, it is
Yeah.
as a first line treatment.
Mhm.
If say that there's a big displacement of that ligament, it's retracted back, I won't do it
Mhm.
because I can't reattach it. Although what we're finding, even with tendons now, if there's less than, maybe 3 millimeters, 4 millimeters, and there's some tissue that's still attached. I didn't talk about this with the ligament work, but we can actually put a fibrin matrix across it
Mm.
that the cells will grow into. And we've seen some pretty big tears that have actually healed, specifically in tendons.
Nice.
Do you see any cons? Is there a negative with this at all, do you think?
There's the only really negative is probably the cost.
Right.
The only other negative is potential for infection.
Mhm.
You can go ahead, some of the patients that fail went on to have a Tommy John. It's not like it precludes you from having surgery. You
And
can
I
go
was
ahead
going to
and do
ask
it
you that question for the therapists that are on, and maybe Ray can jump in on this also with this. But fortunately, I suppose if we look at your trials, there were no complications with any of the patients you included. But are there any common complications? And you just said infection that might come up following PRP injection that physical therapists should keep an eye out for, or something you might see going on with that we should be looking for?
I've done probably several thousand of these now. Never had an infection. Knock wood.
Raymond, what's your take on it?
For me, I think the initial response you'll get from your clients is, I'm hurting more than I anticipated.
Mhm.
I'm localized pain in the area, localized swelling in the area. Is that normal? It looks red. I'm putting heat on it. I want to put cold on it. Why am I putting heat on an area that seems to be inflamed? Why
Mhm.
can't it take anti-inflammatories? It's all against what they've been trained their whole career, or they've seen on TV. It
Mhm.
goes against the grain of what they're accustomed to. So I think that's the initial part for us, is reassuring them, yes, this is part of the plan. This is why are we doing it? Try to explain to them the reasons for it. But that for us, first couple times out is, why do I hurt so much? And if they do a bone marrow also, there's also discomfort at posterior IS, at PSIS. They don't understand why that hurts as well. And explain to them what they did. They drilled into the bone, they pulled up bone marrow.
Then they get it. Yeah.
So then they
Don't
figure out, okay,
that doesn't bother most people.
it's amazing how some people don't understand that they're going to be tender someplace else.
Mhm.
So initially, that's our biggest concern. Our biggest complaint we get from our clients is that. But we've been very fortunate, and certainly I've been 9-10 years with Luga, that I really haven't had a complication post, other than sometimes slow to resolve the swelling. We suspect that they're not doing their homework. Classically, I see them after a period of time, and you kind of can tell whether they were diligent with their home program that Dr. Podesta gave them or not. If I get them, they're hot, swollen, I know they haven't done anything.
Mhm.
But it resolved quickly. We start quickly as we get in some retrograde massage. We're bringing elevation into the area to help decrease some of the compression in the tissue. And then we kind of get caught up where we're supposed to be.
I think you bring up
I'm
a
gonna-
good point, Ray, and I'll just say this to you, and Luga can comment. But one of the things, there's certain things I'm hoping, there'll be some take-home messages tonight, and I know you guys do a pre-rehabilitation process with it, and I know part of that is, and the question will come up because I think we've changed our approach in Nashville with biologics a little bit, but it's that whole washout period of anti-inflammatories and getting on there, because I think oftentimes the patient thinks, oh, well, I like you just said, Ray, I'm sore, and therefore I'm going to be on I'll go back and take anti-inflammatories I might have already had, or do all these things. And to your point, I think there's a big educational piece to this, and that when we start taking the approach with our patients that, hey, there may be some soreness following this procedure, that's perfectly acceptable. We're going with the inflammatory process and doing that and try to get through that. I think that's critical, because as you guys have laid out marvelously in your chapter and in the paper, you described quite nicely what you did for rehabilitation and the importance of rehabilitation with this. I personally think that's 50% of why some of these papers that are out there that show it doesn't work is I think we as physical therapists, or rehabilitation in general, has failed the patient, because we do things that probably are or would be precautions or things we wouldn't normally do, I guess, but contraindicated to the whole process with anti-inflammatory, some of the icing, some of the things we do to control inflammation when that's a part of the process. So I throw it back to you guys, but I know, Dr. Podesta, you wash them out of anti-inflammatories before you do these procedures.
Oh, yeah. Usually depends on the anti-inflammatory. So most, non-steroidals, I'll take them off about 6-10 days before.
Right.
Aspirin's a little bit longer because it stays in the system longer. That permanently damages the platelets as opposed to temporarily damaging the platelets like an NSAID would. But I also take them off of like statins because those are anti-inflammatories, CoQ10, fish oil, some of the nutraceuticals, all that kind of stuff, because that all has an effect. I lecture all the time now on optimization of this. I mean, it starts from the way you draw blood. If you draw blood with a little butterfly or a Vacutainer, you're not going to get any platelet capture out of that, because it causes a turbulence. It causes activation of the cells in the tubing. I use a renal dialysis catheter, which is a butterfly, but it's a big bore tubing. And basically that just flows out. You don't have to even pull on the syringe. So I can get 180 mLs of blood in 30 seconds out without any damage to it. Bone marrow aspiration is totally different. You want to damage the cell because you want to get the pericytes, which are the stem cells, off the microvascular. So you have to apply a force and cause hemolysis. And that's actually a marker of a good bone marrow draw, if you do that.
I'd like to take a
one
minute.
second, Barb.
Mike,
I know we've got a bunch of questions coming in.
I'd like
I'll
to
throw
take
one
a
more
minute.
at you, and then we'll get our questions. But I know you talk about not all PRPs the same, and we talk concentrations, and I think that's obviously a big piece of the puzzle with that. Can you just explain to everybody the difference in terms of preparation, or maybe the potential clinical application, but what it is when they see leukocyte-rich or leukocyte-poor PRP?
Absolutely. So leukocyte-rich PRP is done with usually a single spin type of system. So classically, you'll draw blood, and you've all seen these pictures where you'll see like yellow, then a little white layer maybe, and then red. And it's all done on cell density. So red blood cells are the heaviest cells. They fall down to the bottom of the tube, or depending on how you spin it. The white blood cells are usually in that buffy coat, which is the white layer, and then above it is plasma. But there's platelets that are throughout that whole system. They're most concentrated around the buffy coat, but they can be a little bit above it, a little bit below it. So ACP, for example, or these single test tube type of systems, they spin it once, a small volume of blood, so they're going to get a yellow PRP, and that was always called the yellow gold PRP. Well, it didn't really work that well, and we know that now because the cell content's not really there. Neutrophil-rich PRP, you go below the buffy coat where the red is, and really true neutrophil-rich or leukocyte-rich PRP initially was just taking that little layer of blood. And we know that there's a higher platelet content because we did that study. We looked at it incrementally down the tubing. One thing that we just learned, and we just published this recently, is when you look at the MPV in the cell counts, the mean platelet volume, what happens is when there's any kind of traumatic event to the body, it could be blood drawing, your body sends a sympathetic reflex to the brain to tell the megakaryocytes in your bone marrow to produce bigger platelets to basically compensate for that. If you have a chronic osteoarthritic knee, that's how we found this. You'll get that reflex. And what happens is those bigger, heavier platelets are filled with more granulocytes, which carry alpha granulocytes, which hold more of the growth factors. They're packed with bigger growth factor or more volume of growth factors. They also have a higher volume of serotonin, which is a pain mediator. But they sit way in the red. So you have to take an ml or 2 mLs of red blood cells out, which has always been like forbidden. You don't want red in the cells because of all the different things that we used to see with hemophiliacs that used to bleed through the joints, and it's cytotoxic. But we're not really finding that. The amount of cells that are in there are negligible, and they don't trigger that. We were always taught, putting blood into the joint is going to be very inflammatory. It really is not in reality. You'll get stiff. It's an acute inflammation, which you need to happen for the healing cascade to occur, but it's not chronic inflammation. And I always, when I lecture about what's the difference between all this stuff, when you cut your arm or cut your finger or something, your body dumps blood into the area, you form a clot. All those cells basically work on that clot to heal your tissue. The body's not pulling different cells out, and the monocytes, the neutrophils, they all function in specific pathways, different ways to basically get that tissue to heal. And along that healing cascade, there's different cells that work at different times during that initial 3-week period. That's how that whole healing cascade is driven. And those neutrophils also trigger, and platelets trigger, an angiogenic cascade, which is on top of the healing cascade, which brings microvasculature back into effect and bleeding. So we need all that to occur, otherwise it doesn't heal correctly. From an inflammatory standpoint, if you don't get inflammation, this is not going to work. You don't want a chronic inflammation, and you know that right away, but you want some kind of inflammation. And I tell my patients, after I do the injection, I put the heat pack on them initially in the office. I tell them by 4 o'clock, as I do these early in the morning, you're going to hate my guts. And Ray could attest to it. And we looked at this. I've looked at this probably over 20 years, and with my therapist that couldn't be on, Eric in California, he was noticing the same thing. The worse they hurt, the better their outcomes were.
I would agree with that. Hey, Barb, I know we're going to go rapid fire. You got a bunch, you asked and you got a bunch of questions for these guys.
All right, we're going to see if we can get through a few questions. I'm not sure how many we'll be able to get through. Dan, I'm going to pause on yours for a second. Ian Shattle wants to know, do you look, Dr. Podesta, do you look at the proximal versus distal tearing of the UCL to decide who you're going to do PRP with, or do you make other factors that you've already mentioned?
Initially, we were looking at mostly proximal, although I do distal tears now. It all depends on the morphology of the tear. Proximal, the reason we get these tears in different places and the healing is different is because of blood supply to the ligament. Where on the medial epicondyle of the humerus, there's a very robust blood supply because the tendon attaches there. Mm-hmm. Down on the sublime tubercle, there's virtually no blood supply or very little blood supply. Mm-hmm. So that's much more difficult to get to heal. We can do different things where we can stimulate that, where we drill into the bone with the needle. We'll do those kind of things, or we'll put a matrix on it. Mm-hmm. But usually, I mean, if there's tissue attached on a distal partial tear, I'll treat it. And okay. We have many that heal and do well.
Okay, thank you.
But I look at the whole thing. And one thing that we learned, I mean, I inject, even though I see a specific area of the ligament being damaged, I will treat the whole ligament. I'll treat the flexor pronator fascia and the flexor pronator if that has any pathology.
Awesome, thank you. I think the next one I have is from Liz Grogan. I think this one might be for you, Ray. Sure. Do you ever use BFR training prior to the blood draw? Or do you use it?
You're doing better too, by the way. Hypothetically, she might have had hip surgery recently.
If we do see them prehab, we could use it as a treatment option more times than not, because Luga's down in Florida and I'm in New York. Other than verbal prehab, I haven't a chance to do a lot of physical prehab on some of the clients, unfortunately. When we were in New York, we were, but now we have some distance between the two of us. So yes, it would be a great indication to do that, but we do a post-injection, but certainly not pre-injection.
There's even some emerging literature looking at shockwave therapy or
Mhm.
focal shockwave.
Right. Yeah.
I mean, that's how I met Ashley, was down here. She was giving a lecture on shockwave.
Shockwave. Yeah. Cool. Ian, again, I'm going to dovetail it with the question from Daniel as well. But Ian wants to know, what advice would you give to a patient seeking PRP about asking what type of PRP they're getting? So you've mentioned some of the different types that they're getting. And how is the consumer supposed to know what PRP is more likely to be successful? And a lot of people choose PRP based on price point, but maybe that's not necessarily a quality measure.
You want me to answer that?
Sure.
Um, it's basically the things that I tell people this all the time. I sit down usually for like 45 minutes with patients. I give them the pros and cons, surgical, non-surgical,
Mhm.
how this can benefit, how that can benefit, how it may not or will not, go through the whole thing. But when they're looking for it, to go to a physician for this, I ask them a couple of things. It's like ask them basically if this is going to be guided, it has to be precision. You can't just stick it in because otherwise it's pretty much doomed to failure. They want to know if they can count the cells and know what they're delivering because it's like a drug, it's a dose.
Mhm.
If they can do both of those, they're far ahead of the game. Bioformulations, most docs, uh, a lot of them don't, they're taught one way and that's basically all they know. The surgeons are more apt to use ACP. Some of them are now coming around a little bit more, looking at more of a dosage type thing. They'll use a system called an Angel system. They're all by Arthrex. That's what I used for the majority of my career until recently. I switched because of dosages.
Mhm.
But now I'm going back to Arthrex because I'm actually getting their equipment back to where we need it to be from a cell capture rate and dosage rate. But you got to know what you're putting in. That's the biggest thing.
You're able to do that with the Angel system now. Get it up to your concentration. What is that? What you're
Yeah,
moving?
I can get it up. We haven't really Angels a little bit different than most of these systems because of the way the disc is
Right.
to pull it. But yeah, we can work. It's all about the hematocrit. That's where we think that's going to lie. The higher the hematocrit, the higher that dose because it's dipping down further into the red cell count.
And Daniel's question way at the beginning was about, other than the significant cost differences, are there any significant differences in outcomes with doing PRP versus autologous blood injections? If you would compare and contrast those two.
Yeah, they don't concentrate anything with autologous blood. It's
Right.
basically what you're
It just
doing.
goes. Mhm.
And people did that for a while.
Mhm.
And that's how we naturally heal. But to get a bigger response, especially for what we're looking for, especially in an athlete.
Curiosity, Dr. Podesta, do you find, I mean, because I think concentration is one of the big aspects is, do you find with the patients you see across the lifespan, do you change your concentration based on the age of the patient you see? Maybe that'd be the way I'd say it.
No, I'll change the blood, the amount of blood I take, depending on what their platelet counts are.
Right.
There's, you'll hear all this noise on the internet and about placental cells or birth cells or embryonic cells. They're embryonic cells for an embryo. We produce these cells every day, every couple of hours. Adult stem cells are what we need to use, or progenitor cells.
Maturals, yeah. Mhm. Interesting. And I guess another one, we only have a couple minutes left, but anonymous attendee says, what specific exercise progressions do you give the therapist and is it published anywhere? I think that I can answer part of that. There's some information in your article. Has it changed since you wrote the article? And Ray, maybe you want to hit this one up too, but how much since the original paper has it changed? Is it different?
I've progressed it a little bit, especially from feedback. I mean, one thing from, trained as a physiatrist. I mean, I've been around therapists all my life. I actually became a doctor because I didn't get into physical therapy school. Honest to God truth. My brother got in and I didn't,
Oh, wow.
but it's interesting. It's, I've always been very in tune to this, and unfortunately we had to learn the hard way, but I mean, I rely on guys in like your organization, Ray. I mean, when I moved to New York, I was in charge of a physical therapy department that was at the hospital. I mean, I didn't know these guys very well, and I needed someone that had familiarity with baseball and throwing athletes. And I sought Ray out and found him, and we've been together since. But it's really, I communicate with my therapist all the time. Actually, the first time I met Ashley was I had a Major League Baseball player from the White Sox that came down to see me, and then he wanted to go rehab in Nashville, and I didn't. I said, well, whoever you go to, I want to talk to, because I want to go over what I want to do, whether they're familiar or not. I just want to know where their head is, and I don't want them to deviate too much from what I want to do. So it was Ashley, and the guy had a phenomenal outcome.
Awesome.
And then a year later, we're doing the Shockwave course, and I introduced myself to her, and she's like, "Do I know you? Have we met?" And I'm like, "I don't think so." And then the next day, I gave her my contact, and my contact was in her phone. She's like, "Dumbass, we've already met," And, but yeah, I mean, I think we've progressed it a little bit, and I get feedback. It depends on what the athlete's situation is. If they're progressing a little bit further, they're stable, and we're not in any pain, we'll progress them. If they're not, we'll work a little bit harder.
Which kind of brings me to one of the questions, as another anonymous one, but from a rehab standpoint, both of you, how do you determine the joint's readiness to accept load, and what's the criteria for return to pitching? And when you were speaking, I was thinking the same thing. Are you using objective ultrasound examinations to progress your patients?
That's exactly it. That's exactly it.
And then how frequently?
So when I'll see them about we found on our study around 6.5 weeks on an average, they would pretty much be pain-free with moving valgus stress test, milking maneuvers, stress maneuvers, whatever. So at that point, we ultrasound them. We ultrasound them every month. And what I found was the ligament actually tightened down. I didn't see that instability from the first, the month before to then. It had tightened down. The ligament actually healed. You can see that on an ultrasound.
Awesome.
So that's when I felt we needed to start valgus load, because it was safe at that point. So we gradually started valgus load, and then feedback from the therapist as far as when they felt they were strong enough, that's when we institute throwing. And my throwing programs are pretty, as Ray can tell you, are very, very slow, because I don't want them to overload, because that's how they get into that situation in the first place, especially beginning of the season. And that's how we progress.
We got Barb. Let me throw one at you here. We got Joe Roush, one of our good friends. So the Phillies must not be playing right now, because he'd be sitting in a dugout. So they must have the night off. But shout out to you, Joe. But how does the location of the UCL injury impact your decision on how PRP could possibly be successful? I think you kind of got that a little bit ago, but I know Joe asked this question, so I'll throw it to you.
If it's a proximal lesion in a young kid, I'll do probably just PRP by itself. If it's distal in a young kid and it's not completely torn or off the bone, I'll do a combination of platelets and bone marrow, because of the progenitor cells or the MSCs that are there. It's just a higher load of healing potential and angiogenic blood supply forming potential. If the athlete's a high school kid which high school kid now is not under a big load, a throwing load, typically those I will do a combination of both. Pretty much now, I mean, if they're a high load thrower, I'll do a combination of platelets and bone marrow.
Awesome. In the interest of time, because I've got 8:30 at my house, everybody else is different. Somebody's at 7:30 and whatever else on the West Coast. But I think that we do need to wrap up and allow Daniel to present. So I'm sorry for the questions we didn't get to. We appreciate both of your responses and your information, but we'd love for people to stay on. Even Luga and Ray, if you'd like to stay on and hear what Daniel has to say.
Yeah, definitely.
Awesome. So we're going to keep
Absolutely.
recording.
Thank you.
We're going to keep recording, and just a couple things, because I've now.
And you can share your
amazing I
screen.
can share, but I won't share my screen. You want me to, I can just put a couple things up here, I guess. See if this popped up. Did it share?
Nope.
Hang on.
There
Right
There
here.
it is.
Oh, I got to pull it back. Thanks to our sponsors that we have with all that. We have founding sponsors tonight with us. Been a long time with Envoy and Woodway, Hyper Ice Extra Tools. certainly as Luga talked about with Elevation and Shockwave. And then we have a bunch of gold sponsors. But the news I really wanted to say before Daniel started is that, these Journal Club replays are available. Well, they're on our YouTube channel with the journal, so you can go back and watch them and see things again. We also turn them into podcasts, so they're on Apple Podcasts and Spotify as well. And then the big thing before I turn it back to you, Barb, is that CEU credits available for all those. The fact that I'm attended tonight, the fact that I'm doing it now at the end, you would have to been on 35 minutes or more anyway to get your CEUs. And they will be sent by a third party, Gutenberg certificates, usually within 24 hours of the webinar. We did have the papers in the drive. People were using the Q&A features tonight. So I think it's, again, the biggest thing here was the CEU credit and certificates going out. So with that, I'm going to stop sharing and give it back to you, Barb, and turn it over to Daniel.
Daniel, why don't you go ahead and share your screen? Thank you. This is the first in a series of what we're going to call brief quote unquote case in points. And we'd like to have a discussion after some of these journal clubs with the help of our title sponsor from ATI for the journal club and one of our big sponsors for the journal itself. And again, this is through the IMISCA, the Institute of Musculoskeletal Advancement, which is a shining example of both research and education. So I'm going to turn it over to Daniel Kline, who is the Upper Extremity Fellowship Director for ATI, and have him walk through a brief case in point.
Hey everyone, hopefully y'all can hear me. Thanks for having me on. And yeah, so this is kind of probably a little bit more of a case series. Luckily, I can go in and say all the outcomes were actually 100% similar to Dr. Podesta's. So this is kind of a story of about 5 different athletes that I've had over the past few years. Granted, I've seen numerous of these athletes. We have a college pitcher who had a UCL reconstruction 4 years ago, so he had that his freshman year. We have a high school pitcher who is technically an 8th grader at the time, but pitching for his varsity team at a small private school, no past medical history. High school athlete who is a prime third baseman, has multiple college offers at D1 level. Then we have a minor league pitcher who's 8 years out from a reconstruction that he had in college, and then a college catcher who had no past medical history as well. So just kind of an overview, all these athletes had a variety of different rehabs. Some had formal rehab, but were unable to continue. Others were working with strength coaches and athletic trainers. And then 2 were just kind of, reluctant to comply with rehab and aggravated their injuries by going on to pitch and performing other activities that were unsafe. And this is all prior to their injection. So for us, I work in Greenville, South Carolina with Stedman Hawkins Clinics of the Carolinas. So all of our PRP injections for our baseball players are done by one physician, Dr. Kissenberth, and he uses ultrasound guidance as well. And for kind of an overview of what our program is, we kind of have an early phase 1 of no NSAIDs, no ice. Using heat is the first time that I've ever heard of that, so that's very new to me. We'll have to ask Ray and Dr. Podesta more about that as well. We encourage wearing a sleeve versus a brace for ADLs, and just active range of motion is tolerance with no activity outside of riding a bike. Phase 2, we progress with just gaining back range of motion, trying to get that by the 6-week mark. Again, just very much like Dr. Podesta talked about, we wanted to avoid the UCL valgus stress for at least the first 6 weeks. We are not using ultrasound guidance because we don't have that available in my clinic. And it's really hard to fight with physicians over the ones that are in their clinics. With a progressive strengthening program, so kind of that phase 3 and beyond, we start instituting normal lifting progression and plyometrics progressions for the first 12 weeks. And then we are a little bit slower, and we don't start any return to throwing program until greater than 12 plus weeks. And again, we're using standardized measures of passive range of motion, strength measures, grip strength measures for kind of our progression to interval throwing programs. So early on in the program, what do we notice? In the first kind of 6 weeks, the same symptoms that Ray and Dr. Podesta described. The elbow feels full, feels stiff. It doesn't feel great near the injection site. But other than that, no issues, no red flags, and no infections. From 6 weeks to 12 weeks, Most of these athletes, we see no significant problems have occurred. There's some increased forearm and grip strength soreness developing as they start to use it more and as we start to engage it more in rehab, but pain was never present. During our plyometric program for 12 weeks and after with all these athletes, it kind of goes smooth as we start adding in slow activities. Exercises like what you see here, kind of a variation of an upper body tantrum. These were giving guys more apprehension and fear for returning to the program. We use this as kind of a way to help build some confidence in the arm, as well as some just tolerance to different variations and building speed of movement back in the shoulder. So what happened with all these guys? And all their issues kind of came for them in their interval throwing program or their interval hitting program. For our college pitcher, he had some extended elbow soreness that caught him at around the 120-foot mark as the volume and efforts built up. What we did for him is we augmented his throwing program, did a short 2-week shutdown, if you will. It was play catch because he could play catch but not throw. And then we rebuilt his volume back up, continuing to monitor using IMUs. But he did well and returned at 22 total weeks. When we look at our high school pitcher, he would do well with his PRP program, return to the mound at 20 weeks as well. He was the easy one. With our third baseman, his interval throwing program had no issues, but where he did have some issues was his interval hitting program. Now for him, we started his interval throwing program at 12 weeks, but his interval hitting program started at the 10-week mark prior to the throwing because he wanted to be able to start DHing prior to playing in the field. And so we did have some soreness. That was his lead hand. He was a left-handed batter in his right elbow. So what happened for him is every time he would take his hand off, his top hand off the bat, he would have some extra soreness. So we just worked on the forearm, strengthening a lot more for those 2 weeks, and he had no issues after. Our minor league player accelerated his own program because he needed to be ready for spring training. And so he was able to return in 9 weeks, was pitching all through spring training, and had no issues. And then our catcher, again, very similar. He had some soreness with his interval hitting program, but no issues with his interval throwing program that allowed him to return in 16 weeks. So kind of what did we learn over the years? And again, these are just 5 patients that I've had, gosh, in the past 3 years, where you see multiple of these like Ray does. Respect the inflammatory phase. I think the first 2 weeks, much like Dr. Podesta hit on, is like, this is super important. This is an inflammatory process that has been created to help you heal. So we make sure our patients are understanding that there's no ice, no anti-inflammatories. You can move it around a little bit, but don't overuse it. We restore full range of motion first. We make sure that the elbow has full range of motion and it feels great before we start progressing on to any aggressive strengthening exercises. Because if they don't have full range of motion, that's usually an indicator that the elbow is not happy. We rebuild resiliency and endurance in the forearm and grip strength. So we know through Bert T and others' work that if we can help the UCL out by strengthening up their forearm, by working on flexor digitorum, pronator teres, and flexor carpi ulnaris, we know that we're going to see these athletes have a longer or a lot better longevity in sport. We're also going to allow for extra recovery time. Many of these athletes, what we learned is if you have time, take it. Many of these athletes were able to return fairly quickly because they were wanting to play their senior seasons and junior seasons. But if you have the time, you can take the time, especially with these longer throwing programs. So if you get someone in the summertime and they don't need to be ready until spring, then you have a great chance to have someone healthy for long term. So what I did think would be interesting is, what do these outcomes for these athletes look like? Some of them everyone is over 3 years out. So interestingly enough, pitchers 1 and 2 would go on at their 2 and 3 year mark respectively to have UCL repairs because of subsequent re-injuries. We would have a full recovery on our position players, and they have done great ever since and returned to playing and have gone on to play Division I baseball. And then our player 4 made it through spring training, but would end up having an osteophyte removal and then retire due to skill issues more than injury issues.
Thanks, Daniel. That was really good. And one of the things I think we all noted when we were sitting here, we're kind of looking in the background too, but that you've answered some of the questions that were in the chat actually, or that were in the Q&A with your presentation. So thank you very much for that.
Yeah.
Yeah, it was awesome. Thank you. All right. So thank you everybody for coming. And those of you who, the 189 of you who stayed, we're grateful for everybody. And we're thankful for all of our presenters and everybody to share their knowledge tonight. So we hope to see you next month in July for our journal club. And I think that we're going to sign off at 8:42 p.m. So
Thank you for
thanks
having
everybody
me.
for coming.
Thank you very much.
See you guys.
Awesome. Thank you.